Okay. Hello, everybody. My name is Liz Gallagher, and I'm a paralegal here at Lyles Parker. Welcome to today's webinar hosted by the Home Care Association of Louisiana, HCLA. And before we get started, we actually have Dr. Warren Hebert here to give a little introduction. So let me tell you a little bit about him. Dr. Hebert made his first home health nursing visit in 1985 and has been CEO of the Home Care Association of Louisiana since 1998, an associate professor of nursing for 4 years at Loyola School of Nursing in New Orleans. Warren is now adjunct there and at the Rutgers Institute for Health, Healthcare Policy, and Aging Research. Dr. Hebert is on the expert panel on aging of the American Academy of Nursing and is chair of a new workgroup, Enhanced Home Healthcare Models to Keep Patients and Their Caregivers at Home. Dr. Hebert?
Thank you, Liz, and thanks to Lyles Parker for having the Home Care Association of Louisiana's members and friends join your clients from across the country. A warm Louisiana bienvenue, or welcome to you all. Thanks for being with us today. And because of you, as healthcare professional or office support, home health and hospice services are offered to the eldest at home down to the youngest. The family of an 18-month-old just home from a bone marrow transplant for chronic myelogenous leukemia. That's an 18-month-old. The family was amazed as they watched her toddle around the house with her compact IV pump over her shoulder. She was at home for this care all the way back in 1988. 17 years later, I attended her high school graduation. You all have stories just like this one. Make time to share the stories in your organizations to celebrate your colleagues and celebrate home health care and hospice teams just like yours. Thanks, and thanks again to Lyles Parker and Ashley and Jennifer for this presentation.
Thank you, Dr. Hebert. All right, so let's get started. Today's webinar is entitled Medicare, Telehealth, and Telecommunications, Technology in Home Health and Hospice. And today's presenters are Jennifer Papapanagiotou and Ashley Morgan. I'm going to tell you a little bit about them. Ms. Papapanagioutou's practice focuses on compliance, regulatory, and transactional matters for a wide array of healthcare providers, including home health and hospice agencies. She has extensive experience in analyzing proposed and existing business arrangements for compliance with federal and state fraud and abuse laws and drafting a wide variety of legal agreements. Ms. Papapanagiotou is knowledgeable in all aspects of state licensing for home health and hospice providers and in Medicare and Medicaid enrollment, including initial enrollment, changes of ownership, and appeals of revocation actions. Lastly, she assists clients with compliance plans, forming new businesses, and addressing Medicare and Medicaid program coverage and reimbursement issues. And Ashley Morgan focuses her practice on regulatory healthcare compliance matters, fraud and abuse, and reimbursement issues. Ashley represents healthcare providers across the country in connection with a wide variety of health law issues, including administrative appeals of large alleged extrapolated overpayments, documentation concerns, compliance, medical board complaints, and enrollment revocation issues. Ashley has worked with an assortment of providers, including home health companies, hospice agencies, primary care and specialty physicians, and physical therapists. Ms. Morgan is a certified professional coder and regularly assists providers in claim disputes with major payers, including Medicare and Medicaid. And without further ado, I'm going to hand it over to our presenters, Ashley and Jennifer.
Thank you so much, Liz, and thank you, Warren. Thank you all for being here this afternoon. We look forward to going over today's presentation on Medicare, telehealth, and telecommunications technology in home care and hospice. Liz, you can go ahead and advance to the next slide, if you don't mind. So just a brief disclaimer, today's presentation is just informational in nature. It does not constitute legal advice. You should always contact your own legal counsel with specific legal questions. Next slide. So this is an overview of the topics that we're going to cover today. I'm sure, as you all know, telehealth is an ever-evolving monster right now with COVID, so we're going to try to touch on some of that. We're going to start with some background info on telehealth, then we're going to talk about COVID-19 public health emergency waivers. We'll go over some Medicaid flexibilities, the Louisiana telehealth landscape, and then talk about what's to come down the pike in the future. Okay, Liz, next slide. All right, let's start off with a discussion of telehealth. Go ahead, Liz, next slide, thank you. So here's just a couple of definitions. Telemedicine is specifically remote clinical services. So your diagnoses, your assessments, consultations, treatments, these are being provided real time by physicians or other licensed providers like nurse practitioners that are acting under physician supervision. Telehealth, on the other hand, is kind of an overarching term that covers all healthcare interactions that are not taking place in person, including the use of electronic information and telecommunications to support long-distance clinical healthcare. So all of your interactions, like through portal, messaging with a physician, that's all covered under telehealth. Telehealth is broader than telemedicine because it can include non-clinical services, and it can also include provider training, administrative meetings, and continuing education. Next slide. So telemedicine and telehealth is absolutely rapidly changing. It's changed quite a bit since the COVID-19 pandemic began, and it's still ever evolving today. And in addition, there are differences in what's permitted depending on which state you're situated in. States have, the authority to make their own rules and regulations about what providers can and cannot do. And these differences can be very subtle, so it's important to understand what the rules are for the state that you're situated in, where your patients are situated, and where you're licensed. And again, the COVID public health emergency does allow for specific waivers, but again, these waivers may or may not persist when the public health emergency expires. Next slide. So I want to go over what some of the different terms are for different technologies utilized in telemedicine. These are defined within the U.S. Code. So an interactive telecommunication includes audio and video equipment permitting two-way real-time interactive communication between a patient and a physician or practitioner. Asynchronous includes transmission of a patient's medical information from an originating site to the physician. This can include, something like email, that's asynchronous, for example. The originating site is where a patient is. A distant site is where the physician or practitioner is located. And non-simultaneous is assessment and evaluation after the fact, such as teleradiology. And states, again, this is going to be a continuing theme. States can have different explicit definitions of what technology is permitted, just like they can have different, rules and regulations on what forms of telemedicine are permitted. Liz, go ahead. So federally, HHS, Health and Human Services, have identified 4 different modalities of telemedicine technology. There is a live two-way interaction via a video visit. There's mobile health, which is through a phone application on your, iPhone or other smartphone, an Android. Remote patient monitoring, such as a Holter monitor, and then store and forward technology like digital radiology interpretation. In Louisiana, these are the definitions for telehealth and telemedicine. So for telehealth in Louisiana, It's defined as healthcare services, including behavioral health, provided by a provider to a person through the use of electronic communications, information technology, asynchronous store and forward transfer technology, or synchronous interaction between a provider at a distant site and a patient at an originating site. Telemedicine, on the other hand, is defined as healthcare delivery, diagnosis, consultation, treatment, and transfer of medical data by a physician using technology that enables a physician and a patient at two locations to interact. And the technology may include electronic communications, information technology, asynchronous store and forward technology, or technology that facilitates a synchronous interaction between a physician at a distant site and a patient at an originating site. So you'll notice there that it does say that asynchronous can be considered telemedicine. So portal transfers, for example, between a physician and patient can be considered telemedicine in Louisiana. So that's an important distinction because you'll note that that's not defined as telemedicine by HHS. So technologies that are not considered telemedicine in Louisiana would be email unless it's HIPAA compliant. So for the asynchronous definition, if you're gonna, correspond via email, it needs to be HIPAA compliant. Same for text messages, they need to be HIPAA compliant. So you need to be using some sort of technology that allows for that transmission to be protected under HIPAA. And fax also is not considered telemedicine. And there are some limitations and issues that Louisiana has recognized, such as the lack of broadband access in rural areas, and the speed of access, the quality of resolution. That can really impact, for those of you that service patients in rural areas, it can really impact the ability to receive telemedicine services. So there are some situations where Louisiana will consider the use of audio only for telemedicine, but it does, it's a limited option. So it needs to be clear that it was required that the audio use needed to be used because of the limitations on broadband. And we can go to the next slide, Liz. We have a map that shows in Louisiana, where there's access problems to internet in Louisiana, where there's limited access. You see all the yellow, those are areas with very limited access to broadband, as opposed to the blue where there is, significant access to broadband. So there are, quite a few areas in Louisiana with limited or no access to broadband still. And that explains why, in some situations, Louisiana is permitting providers to still use audio only for telemedicine. Okay, Liz, next slide. Okay, so I'm going to go over for Medicare specifically, what was allowed for telemedicine before the public health emergency. So pre-COVID, there were certain situations where telemedicine could be utilized, but they were very specific. So it had to be a service that was specifically listed on the Medicare approved telehealth services. It had to be furnished via interactive audio and video that permitted real-time interaction with the patient. It had to be furnished by a physician or another approved provider. It had to be furnished to an eligible individual, and it had to be the individual receiving the service had to be in a telehealth originating site. And if we go to the next slide, I'll show you where the originating sites were defined. So the only originating sites were physician practitioner offices, critical access hospitals, rural health clinics, hospitals. So there were very limited areas where telehealth was in fact permitted prior to COVID. That obviously has changed, and we're going to talk about that as we move forward through the presentation. We just wanted you to have an understanding of where we started before we go to where we are now and what's to come. So something to think about is HIPAA always, especially when we're transmitting information electronically. The same requirements apply to telemedicine as regular face-to-face interactions and services. So you still need to make sure you're HIPAA compliant when you are transmitting information, even if you're utilizing telemedicine. The minimum requirements for a telemedicine system are there's full encryption of any and all data systems. There's no storage of video transmissions, and you have secure peer-to-peer networks and connections. Some issues you want to think about are that people could potentially be using unsecured mobile devices, such as their iPhones or their Androids, or systems like non-secure email or text messages. So you need to be very careful about that. You need to make sure that if you have providers that are utilizing telemedicine, that they are using secure devices and that they are using secure systems, secure messaging through a portal, for example. Also, other issues are that staff really doesn't have great training about technology or HIPAA compliance, so you should ensure that your agency is conducting HIPAA training at least annually, and that you include specific training on telemedicine and what is permitted for your providers to do. A lot of providers do not discuss telemedicine in their notice of privacy practices, so we suggest that you take a look at those notice of privacy practices if you are utilizing telemedicine. Many providers don't actually have a business associate agreement with their telemedicine providers, so that's something that you need to consider as well. And always need to make sure that your employees are updating their passwords on a regular basis, and that they all have their own unique logins that they use. We don't want to share logins as well. Next slide. So for the duration of the public health emergency, the Office of Civil Rights has made some waivers for technology. So prior to the public health emergency, Skype and FaceTime, for example, were not secure and were not HIPAA compliant. That you've been permitted to utilize systems like Skype, FaceTime, Zoom during the duration of the public health emergency. Again, the public health emergency will at some point in time likely end. And so you need to make sure, to the extent that if you're still utilizing Skype or FaceTime or some other non-secure system for telemedicine, that you consider transitioning towards a secure HIPAA compliant system. You need to make sure that if you are going to continue to use telemedicine or telehealth, that you have your HIPAA policies updated to address the use of those systems and the security measures that you have in place. Again, you need to make sure you're training your staff and that you specifically address how they're supposed to utilize telemedicine, the devices that they're permitted to use, changing their passwords, etc. I also need to make sure that everybody is updating their software. There's always software updates pushed out, that you need to make sure that staff are actually updating their software so that the devices remain secure, because a lot of times those updates address bugs and issues that can cause security breaches. And it's also important to remember that the minimum necessary rule still applies even during the public health emergency. So you're only disclosing the minimum necessary amount of information about a patient, the minimum necessary amount of PHI that needs to be used to make sure to provide treatment without over disclosing information that somebody might not need. And then again, you need to make sure if you have a breach, that you're responding appropriately and that you're monitoring to make sure that you don't have a breach, or that you can address something quickly if somebody does report a breach. Right, next slide. Okay, and now Jennifer is going to talk about the COVID-19 public health emergency waivers.
Thank you, Ashley. Let's go to that. Yeah, great, thank you. So just to give you a little bit of background on where the waivers sprang from when the COVID pandemic began. So there's existing federal law that allows the president to declare a major disaster emergency if they're asked to do so by the governor of a particular state. And in addition to that, the Health and Human Services Secretary is also allowed to declare independently a public health emergency. Actually, in the COVID pandemic, the HHS Secretary's declaration came before the President's declaration, which kicked off a process under existing law that allowed the Medicare program and the Department of Health and Human Services to start considering certain waivers of existing rules that are permitted under existing law. So a public health emergency by legal definition is for the duration of the emergency or 90 days, and it may be extended. And it has, in fact, the COVID public health emergency has been extended numerous times. Once a public health emergency is declared, that triggers a particular section of the Social Security Act, which allows the HHS Secretary to temporarily waive or modify certain requirements of the Medicare, Medicaid, CHIP programs, and under HIPAA. HIPAA is under the Department of Health and Human Services Office of Civil Rights, so it falls under the same authority as Medicare, Medicaid, and CHIP under the Secretary of Health and Human Services. Secretary Azar declared the initial public health emergency. So this is the HHS Secretary declaration on January 31st, 2020. That was retroactive a few days, and it has been renewed multiple times. Right now, it is set to expire May 11th, 2023. I don't expect an additional extension beyond that date. There's a tremendous amount of communication coming out of both the White House and the Department of Health and Human Services to prepare everyone for the end of the public health emergency. So I anticipate this is real. This is a hard date. We're going to have to be sure we're all doing the right thing to come into compliance as of May 11th, 2023. So let's go to the next slide. So specifically with regard to Medicare and telehealth, there was a Section 1135 waiver that was effective March 6th of 2020 that lifted many of the restrictions that had currently existed with regard to the reimbursement for telehealth services under the Medicare program. As Ashley mentioned, it was pretty restricted. Patients had to be in a particular originating site, which did not include their home, and it was only permitted in rural areas. So as of March 6, 2020, they lifted those two restrictions, and telehealth could occur anywhere in the United States, whether it was rural or not, and the patient could receive those services from their home, and Medicare would cover those services. This allowed certain waivers to allow certain services in the home health and hospice environment to proceed while patients were in their homes, which, as you can imagine, was really important during the public health emergency. So let's go to the slide. This is important, and it's important to understand sort of how does the telehealth waiver and allowing telehealth services to take place while the patient's in their home in any location, how does that affect home health? Well, we all sort of depend in the home health environment on that face-to-face encounter for billing purposes and for many other clinical reasons. What the public health waivers allowed were those face encounters could happen between the physician or practitioner and the patient via telehealth. And the waiver specifically allowed the use of two-way audio video technology for that face-to-face encounter when the patient was in their home. Again, this was a tremendously helpful relaxation of the existing Medicare policy. And there has been a tremendous amount of pressure over the last year to 18 months to extend this waiver and allow Medicare telehealth services in general to be to lift this originating site restriction that exists under statute, and to also allow telehealth services to continue regardless of where you are geographically beyond the public health emergency. And we had originally had an extension of these waivers for 151 days after the end of the public health emergency. That was passed back sometime in 2022. And fortunately, in the most recent Consolidated Appropriations Act that was passed at the very end of December of 2022, they were able to include a continued extension of this particular waiver until the end of 2024. This is something people have been pushing for in the community, in the provider community, for quite a while, and it got tacked onto that appropriations bill. So we now have an extension of the originating site waiver and the rural area waiver through the end of 2024. That's pretty big news for all of us in the healthcare industry. Let's go to the next slide. Okay, so unlike that, the home health agencies, obviously during the public health emergency, have been allowed to provide telehealth services via telemedicine type platforms to patients using telecommunications technology within that 30-day period of care, as long as it's part of the patient's plan of care and doesn't replace needed in-person visits as ordered on the plan of care. And this could be a combination of different modalities, remote patient monitoring, phone calls, or two-way audio-video technology. As long as those were specified within the patient plan of care, agencies could use those. And that was a specific waiver that was put in place during the public health emergency. Medicare, in its infinite wisdom, thankfully, has agreed to make that permanent beyond the end of the public health emergency. So home health agencies can still continue to take advantage of these telecommunications technologies, although there are certainly some limitations. Medicare still won't reimburse for these services, for example, so they don't get you extra money. That, however, of course, doesn't enhance the quality of care that's being provided, or allow agencies to more closely monitor patients sort of in between those in-person visits. So it's great news for the clinical side of care and keeping patients, from decompensating and from ending up back in the hospital or the emergency room. But we're still struggling to get Medicare to recognize that those services should be reimbursable, at least within the home health environment. One thing to keep in mind is that while this ability to provide care via telecommunications technology will continue indefinitely past the end of the public health emergency, once the PHE, the public health emergency, ends, you must be using a HIPAA compliant platform to render these services. They are not extending the waivers regarding the technology you use past the end of the public health emergency. So that is something everybody needs to be preparing for. You've got to be if you haven't already done it, you need to be moving toward a HIPAA compliant platform for these kinds of interactions. Let's go to the next slide. Okay. Home health aid supervision was another area. They, during the public health emergency, wanted to limit the number of people going into the home, and this included supervisors who would be doing those every 2-week visits to evaluate the care provided by aides. So this actually was modified by the 2022 Home Health Payment Final Rule, and they essentially said you can justify one virtual supervisory visit every 60 days for a patient, but it should only be done in rare instances, circumstances outside the home health agency's control, and you must have documentation in the medical record detailing why you're doing the supervisory visit virtually and not in person. They're trying to accommodate those instances where perhaps the patient has COVID or other contagious illness that you want to limit contact. But again, the home health aid supervision standard has essentially reverted back to what it was as the effective date of the 2022 Home Health PPS payment rule. All other required visits that are ordered on the plan of care have to be done in person now. So again, you use telecommunications and telehealth technology to fill in between those in-person visits, but again, they're non-reimbursable, and all of the ordered in-person visits have to be done in person. Okay, look at the next slide. We're going to switch around and talk a little bit about hospice because the rules are slightly different. There was a waiver at the beginning of the public health emergency that would allow petitioners who are doing face-to-face encounters for recertification for the Medicare hospice benefit to do those using two-way audio-video telecommunication technology. Congress, in that appropriations bill I mentioned earlier, has extended this waiver to the end of December 2024, so that's very good news. Again, as of the end of the public health emergency, those practitioners are going to have to be using a HIPAA compliant platform for those recertification visits. It's important to home health and hospice agencies to understand that, because you're going to be relying on whatever platform and whatever record is created as a result of that vacation visit or a face-to-face visit for home health, for example, to support your billing for your home health or hospice services. So you do need to be looking at the documentation you're receiving for these and making sure everything looks copacetic, and that the practitioners are meeting, the requirements they should be meeting for providing services in a HIPAA compliant way. So let's go to the next slide. Like home health, hospices have been permitted to provide certain services via telehealth. They can specifically provide services to a Medicare patient receiving routine home care through telecommunications technology. Again, things like remote patient monitoring, phone calls, and two-way audio video technology is feasible and appropriate to do so. Medicare went so far as to say this would include the initial and comprehensive assessments, but hospices were reminded that they need to be able to fulfill requirements of these assessments and use their judgment as to whether that a telehealth assessment is feasible in each particular patient's case. Like home health, only in-person visits were to be recorded on a hospice claim, so you don't get compensation for or enhanced compensation for using telehealth, but it could be utilized to provide sort of some enhanced level of service to patients during the public health emergency. This waiver is going to expire at the end of the public health emergency. So again, everything is going to have to revert back to the way it was before the public health emergency went into place. Let's go on to the next slide. Ashley mentioned earlier that there were some waivers put in place at the beginning related to the type of technology that could be used to provide telehealth and telemedicine services. So effective March 17th, and for the duration of the public health emergency, the HHS Office of Civil Rights came out and said they would exercise enforcement discretion and not impose penalties for the use of non-compliant, non-public facing telehealth technologies. This waiver applied to the use of telehealth for any reason. It didn't have to specifically be for something related to COVID-19. OCR did make some recommendations that patients or that providers notify their patients that if they're using a technology that's not HIPAA compliant, they wanted providers to tell their patients that, so the patients have choice. Providers were encouraged to enable all privacy and encryption modes or settings that they could with whatever technology they chose to use. OCR went so far as to explicitly sanction the use of FaceTime, Facebook Messenger video chat, Google Hangouts, Zoom, Skype, GoToMeeting, and WebEx type platforms. But they specifically did not say, okay, to use a public facing chat or interaction tool. I remember them mentioning TikTok is not okay, which sounds hilarious, but no, there's all sorts of types of communication these days. This waiver, as we mentioned earlier, is going to expire May 11th of 2023. So everyone needs to be prepared and has, if they're going to continue to use this type of tool, they need to be prepared to use a compliant tool. Let's go to the next slide. I'll talk a little bit about specific waivers or exceptions that were created in Louisiana during the public health emergency, and before that, in fact. So Louisiana has been working on access to telehealth for a while now. There was an act passed in 2014 that it essentially was to encourage the expansion and use of telehealth for people within the state of Louisiana. And it sort of set the groundwork for expanding the access to service and getting those services paid for. In 2016, the Louisiana State Board of Medical Examiners also implemented sort of a telemedicine licensing structure. In-state providers were expressly, if they have a physical practice location in Louisiana, they could render services via telemedicine to people physically located in Louisiana. They were not permitted to provide care to a patient physically located outside the state of Louisiana unless they had been given the authority to do that by the state where the patient was located. They also created an out-of-state permitting structure for telemedicine. So if a physician didn't maintain a physical practice location in Louisiana, they could apply for a telemedicine permit to have those interactive communications with people who are residing in the state of Louisiana. During the public health emergency, there were a number of temporary telehealth licenses that were issued to providers, especially providers out of state, obviously. All those temporary permits expired June 14th of 2022, which was 90 days after the Louisiana state of emergency expired. So that's just something to be aware of. I think it's probably unlikely that you'll be seeing physicians from out of state providing, for example, face-to-face encounters for home health or hospice patients, but it is something to keep an eye on. If you do happen to see that, it might be worthwhile to verify that that practitioner or physician has a license in Louisiana to provide that service. There were certain disclosures that the medical board recommended when you're providing telemedicine services. Really pertains to physicians specifically, and I've listed those here. This is very similar to what most states are requiring for telemedicine services when a physician is providing that service. And again, these are specific rules for physicians providing telemedicine, not necessarily applicable to home health and hospice and types of services you may be providing by telehealth. Let's go to the next slide. So the Louisiana State Board of Medicine did come out during the public health emergency and align itself with the U.S. Department of Health and Human Services Office of Civil Rights to allow the use of non-public facing applications for video, two-way interactive video. So they expressly said it was okay for we use FaceTime, Facebook Messenger, Google Hangout, Zoom, Skype, all of those modalities that were described by OCR as acceptable during the public health emergency. And obviously they did not approve of public facing applications, Facebook Live, Twitch, and TikTok. This particular relaxation of the type of telemedicine platform you could use in Louisiana will end with the end of the public health emergency when OCR and its relaxation of its policies ends. So there's some specific provisions under Louisiana regulations that generally two-way video is required for a telemedicine visit between a physician and a patient. But they do say that a physician practicing by telemedicine may use interactive audio without the requirement of video if they determine it can be done safely and will provide the same standard of care. And as Ashley mentioned earlier, when a patient resides in a rural area where they may not have sufficient internet access in order to do two-way audio video, audio only can be appropriate, but it's always caveated by this. It still has to be appropriate to the patient and their particular condition. So it's still, the physician still has to be able to provide the same standard of care. It needs to be appropriate in that particular circumstance. There are some statutes that include specific telemedicine physician standards. I don't want to go into that in too much detail. Y'all aren't physicians, but it's important just to be aware of what to look for in the documentation you're receiving from physicians if the services were rendered via telehealth, telemedicine. Let's go to the next slide. There were some very specific rules about ordering prescriptions for physicians. Telemedicine couldn't be used unless the physician had at least one in-person visit with the patient in the past year. From what I've reviewed and what I've seen, this is still a standard that's in effect. And again, no physician practicing telemedicine can prescribe a controlled dangerous substance prior to conducting an in-person patient history or physical exam. These are rules, again, put out by the medical board to govern what physicians can and can't do via telemedicine. Let's go to the next slide. So Louisiana's COVID emergency expired March 16th of 2022, which affected many of the policies and waivers and things they had put in place during that time period. You still have the bit of certain, obviously, federal waivers that we've talked about previously. But let's talk a little bit specifically about Louisiana Medicaid and what they're allowing these days. So they are still permitting things like remote monitoring, health status monitoring, medication dispensing and monitoring are all forms of remote patient monitoring that are covered by Louisiana Medicaid and will continue to be covered going forward. They've also come out and said they encourage the use of telemedicine and telehealth when appropriate for any and all healthcare services, not just those related to COVID-19, when the COVID-19 related restrictions are necessary as outlined by the governor or state public health officials, which is kind of given with one hand and taken with the other. Since the state COVID emergency ended in March of 2022, I'm not sure how generous this really is. But it is clear that Louisiana Medicaid will, in the circumstances, allow telehealth and telemedicine for many common healthcare services, as long as they appear on this particular CPT code list that's referenced, Appendix P of the CPT codes. So they be rendered via synchronous audio and visual telecommunications systems. Again, this is for Louisiana Medicaid. They're focused on this being live, two-way interactive communication. Examples of the types of services that are payable would be psychiatric diagnostic services, psychotherapy, crisis services, prolonged service outpatient visits, and prolonged service inpatient visits. There's some specific coding requirements under Medicaid. When you're doing telehealth and telemedicine, they use modifier 95 and follow, the traditional ICD-10 diagnosis coding guidance and whatnot. They also have guidance on place of service coding, whether that's home or other than home, with a modifier 95, so they're pre-identified as telehealth. Let's go to the next slide. Louisiana Medicaid only reimburses the distant site provider, and under Medicare telehealth, there's because of its originating site restriction prior to the public health emergency, both the originating site, which could be a physician office, could be a hospital, they could receive some reimbursement, and then the distant site provider was also receiving reimbursement. Louisiana Medicaid does not do that. They only reimburse the distant site provider. It is, however, a payment parity state, which basically means that private payers are required to reimburse telehealth visits that are legally performed under state law at the same payment rate or amount as if the care had been delivered in person. Most states have a rule similar to they can't pay you less just because the service was done via telehealth. And then effective January 3rd, 2022, the Medicaid managed care organizations were instructed to automatically approve the initial authorization for home health services at hospital discharge. So instead of a prior authorization, the hospital or the home health agency sends the MCO a notification of services that an enrollee will receive after discharge, and the EO shall subsequently approve that initial authorization for service. Subsequent authorizations have to meet recertification requirements. So that was a bit of a relaxation of prior policy. So with all that in mind, let's go to the next slide. Ashley and I wanted to touch on sort of what do we see coming down the pipe in the future. Ashley?
Yeah, thanks, Jennifer. So as Jennifer referenced earlier, the Consolidated Appropriations Act of 2023 was recently passed, which did provide that certain flexibilities will continue up until December 31st, 2024, even if the public health emergency ends before that date. So again, that specifically allowed for beneficiaries to continue to receive telehealth services at any site, regardless of the type or location. So for example, they don't have to be in a rural area. The originating site is fine if it's the beneficiaries at their home. So hospice physicians and nurse practitioners can continue to complete certain requirements related to patient certifications via telehealth. So that's a big deal that was recently passed that allows that to continue. And it does represent a huge change to current Medicare coverage of telehealth by permitting the waiver of the originating site requirement. So, we'll see if this continues after 2024, but for now, even if the public health emergency does end in May, this is going to be continued through the end of 2024.
Yeah, and I would just add to that there's certainly, I would anticipate they will continue, the stakeholder communities will continue to push for a permanent change to the originating site and rural area requirements under the Medicare statute. It's written into the law, which is why it's never been changed prior to the COVID pandemic. It actually required a statutory change. And I know that from the folks I hear from within Medicare, within CMS, all evidence seems to point to the fact that the expansion of telemedicine has been a good thing. It's been good for clinical care. It's been good for the provider community. And I would anticipate they're going to look at a more permanent solution past December 2024. There is, within the Appropriations Act, they also, I have instructed, I assume HHS to do a study of telemedicine services and provide a report no later than 2026, I believe, which sounds like a long time, but government agencies move very slowly. And I think they want a large enough window of time to look at that they get what they consider to be good quality results from that study. So I wouldn't be surprised at all if we get another extension of the originating site waiver past 2024 until at least the time when CMS or HHS is required to report back on telehealth in general.
Next slide, please. And so kind of to play off of that. CMS in the fiscal year 2023 Home Health Prospective Payment System final rule. This was issued in November of 2022. It discusses the collection of data regarding the use of telecommunications technology, and they are establishing specific G codes to identify when home health services are furnished using telehealth and technology. So there's a couple different G codes. We're going to talk about those in the next slide. But there's a specific one for synchronous telemedicine rendered via audio video, one for synchronous telemedicine rendered via audio only, and for the collection of data such as remote patient monitoring. So right now it's voluntary to report these codes when you're utilizing technology and telemedicine. However, starting in July, on July 1st, 2023, it's going to be mandatory to report these codes. So it's important that you know what the codes are. But this is just, again, these are just reporting codes. You're still not going to be reimbursed for these services during this time, but they are reporting codes that CMS can collect data on this information and how telemedicine is being used, theoretically, to see if there's going to be any additional changes on a statutory or regulatory basis. So these are the three codes. So we've got G0320, that is for synchronous telemedicine rendered via audio and video. It's supposed to be reported for each service as a separate dated line under the appropriate revenue code for the discipline that's providing the service. The G0321 is for home health services furnished via telemedicine via telephone or other audio only. Again, same rule, report each service is a separate dated line under the appropriate revenue code for each discipline providing the service. And for G0322, this is for the collection of data that's digitally stored and or transmitted to the patient by the patient to the home health agency, such as through remote patient monitoring. And this is, you're supposed to report remote patient monitoring that spans a number of days as a single line item, which shows the start date of monitoring and the total number of days of the monitoring. The total number of days goes within that unit field on the claim form. So again, this is a very interesting development. You're going to need to make sure your billers understand what these rules are, because you are going to be required to report these starting on July 1st. And Liz, can you go ahead and go to the next slide? So the new G codes are not considered a home visit for purposes of patient eligibility or payment. They're not considered a visit for calculating your loop of payments. So you still need to make sure your providers are going out and providing those actual in-person visits to actually qualify for your visits for home health care, but you are, again, permitted to continue to use these telemedicine options, but you need to make sure that you are now, I would start implementing the use of these G codes while it's voluntary, so that you get used to reporting those, so that when it comes time in July that those have to be reported, you already have systems in place so that you're in compliance.
So, and this is Jennifer, I think Ashley said, this is a very interesting development, and it is, and I think this is for two purposes. One, they'd like to know how many agencies are using telehealth, telemedicine type technologies, and at what frequency. And that would naturally lead to a discussion about payment and whether there should be some enhanced payment for agencies that are utilizing these services. So I think this is a good thing. I know it's an administratively burdensome thing, especially at the beginning while everybody kind of gets used to the process, but I'm hoping it leads in a direction of, perhaps allowing agencies that are good at this and that integrate it into their operations, that they show both clinical benefit for patients, but also can perhaps get some reimbursement for those telehealth services on top of their regular in-person services. So with that being said, Ashley and I are happy to answer a couple questions if you want to type something into the chat box, or you're more than welcome to contact us via, I will say it's probably easier to get us via email. There are our email addresses here on the back, last slide, and I believe everybody will receive a copy of the slides after the presentation, so don't feel like you got to quick scribble it down right now. So any questions, Liz? Do we see any questions popping up?
There was one question that was submitted a little earlier in the presentation, and you might have already touched on it, but I will read it over and you can talk about it again. Somebody asked, I thought home health telehealth visits had to be two-way communication. Is that not true?
It really depends on the type of visit you're talking about. If it's home health agency touching base with a patient using one of the various types of technology, as long as you can use remote patient monitoring, you can use phone, you can use two-way audio video to do the home health agent services. Again, they're not reimbursable, and now you're going to have to begin reporting those services under those G codes that we just mentioned. The face-to-face encounter type visit between a physician or other appropriate practitioner and a patient can be done using two-way audio video telecommunication. So, Medicare has not relaxed that requirement. They don't want audio only for things like a face-to-face visit. The research visits, my understanding, and I can certainly, if the person who asked this question is still listening and they want to email me, my understanding is those have to be done by, this is for the hospice research visits, those have to be done by two-way audio video. And again, that's been extended to the end of 2024. And again, my understanding is for the hospice research face-to-face encounter, it does have to be done by two-way audio video. I think that answered the question, but if I didn't get all the aspects of it, feel free to touch base via email or phone.
Okay, we have one more person who chimed in here at the end with a question. Do you anticipate a review scrutiny by providers who use the G codes for telehealth to ensure billing was accurate? That was a lot.
I mean, Ashley can give her opinion of that. I think right now I really think it's intended for data collection, not going to necessarily be a point that's audited heavily. Time will tell. I think they want to encourage providers to report these codes so that they can collect information on what agencies are doing. And it's to your benefit to do that so that they can consider whether they want to further relax how certain services are delivered by agencies and allow some things to be done, or to add compensation or enhance compensation where agencies are utilizing telehealth, telemedicine for specific purposes. So do I think it's going to be low-hanging fruit for audit? Not initially. I really think this is more of an information gathering by CMS. Ashley, do you have any other thoughts?
I agree. I think right now where it's being rolled out and there's not reimbursement for those visits, I don't see a lot of audit risk specifically. Obviously, that could change, especially if they do start reimbursing those services. But I think, at least for right now, I don't see a lot of audit risk there specifically.
All right. Any other questions?
That's all from our participants.
Well, thank you, everybody. This is Jennifer. I appreciate your time today. Again, feel free to reach out to me or Ashley. Ashley, any parting words?
No, thank y'all so much for joining us this afternoon, and I hope you all have a wonderful, wonderful rest of your day. Thanks, Jennifer. Thanks, Liz. Thanks, Lauren.
All right.